With patient assessment regarding breath sounds, you will hear 4 types of breath sounds over normal lungs. The type of sound you hear depends on where you listen. So we're going to have tracheal breath sounds, which are heard above the supraclavicular notch, just over the trachea. Again, there's also going to be bronchial breath sounds just above the clavicles on each side of the sternum, over the manubrum. We're also going to hear bronchovesicular sounds next to the sternum on both sides. And then there's going to be vesicular breath sounds heard on the remainder of the lungs. We also need to assess for adventitious or abnormal breath sounds. These are sounds that are heard in addition to the expected breath sounds we mentioned earlier. It could be caused by fluid or inflammation, one of which would be stridor. So you can see this is where we already talked about stridor in the earlier class, where we said it's usually high-pitched. You hear this wheezing sound that's caused by disrupted airflow, usually in the upper airway over the trachea as a result of foreign airway obstruction. So let's listen and see what stridor sounds like. We would also have wheezing, which is that squeaky sounds that are heard during inspiration and expiration, also associated with narrow airways. So again, wheezing, it affects the bronchi as a result of constriction, as a result of air trying to pass through the bronchioles. Again, we can see this condition with clients with asthma or bronchitis. So again, let's look at what wheezing sounds like. Again, there's also rhonchi. It's kind of a musical sounds or vibrations that are commonly heard on expiration. With rhonchi, you usually see it as a result of obstruction of fluid accumulation in the larger airways. Again, this is what rhonchi sounds like. With rails, you hear this kind of crackling. Okay. So with rails, we hear this kind of, sorry. So this is what rails would sound like. With rails, you're going to hear crackling or goggling sounds that are commonly heard on inspiration. So again, rails are those crackling sounds as a result of happening in the smaller airways. You have fluids in the lungs or the alveoli as a result of CHF or pneumonia. So again, let's look at what rails sounds like. Also, we need to assess or percuss what we refer to as the costovertebral angle. So the costovertebral angle is located posteriorly between the 12th rib and the spine. So this is our spine, this is the 12th rib. So the costovertebral angle contains the right and left kidneys anteriorly. So if either of the kidneys is inflamed, maybe due to an infection, a firm thump to this area would cause pain. So again, we want to take note of that as part of our physical assessment, so we know we need to assess the kidneys in these areas. Again, with heart sounds, there's a mnemonic to remember the heart valve. So again, toilet paper, my ass. Toilet paper, my ass. So that reminds me that the T in toilet is for the tricuspid valve, and then the blood flows into the ventricles and out through the paper, which is a pulmonary valve or the pulmonic valve. Again, on this other side, the blood comes in through the mitral valve, that's a MI, and then it leaves through the aortic valve into the aorta. So that's one way to remember your heart valves. But with heart sounds, you want to remember that the first heart sound, our S1, represents the closure of the AV valves. What are our AV valves? The mitral valve and the tricuspid valve. So that's our mitral valve and our tricuspid valve. So when these valves close, when the atrias have pumped blood into the ventricles, you are going to hear your first heart sound, which is our S1. It usually has a dull quality and low pitch. It indicates the onset of ventricular systole or ventricular contraction. And then there's a second heart sound, or our S2, and it represents the closure of the semilunar valves. Which are our semilunar valves? That would be your, we said our semilunar valves are our aortic and pulmonary or pulmonic valve. So that's our pulmonic valve and that's our aortic valve. So when these valves close, we're going to hear our second heart sound. Again, it has this snapping quality, kind of snapping sound, and it indicates the onset of diastole, which is a relaxation of the atria and then the ventricles. Again, we could also hear our S3 sound, which can be normal. It could be a normal finding in children, in pregnant females, in well-trained athletes. And then there's our S4 sound, which is almost always abnormal, especially when it's loud. It's a sign of a pathological state, usually a failing left ventricle. So you want to take note of that. Our S4 sound is usually an abnormal sound. When it's loud, it's a sign of a pathological state, usually tells us the left ventricle is failing. Again, if I see the presence of S3 and S4 heart sound in my patient with maybe an overproduction of growth hormones, maybe the patient has a pituitary adenoma, I'm already thinking of heart failure. So again, you want to relate with your S3 and S4 heart sounds. We must also assess for the point of maximal impulse, or our PMI. That's actually the location at which the cardiac impulse can be best palpated on the chest. This is usually at the left fifth intercostal space at the mid-clavicular line. So that's our point of maximal intensity. We said it's at the left, so there's our left, at the left fifth intercostal space at the mid-clavicular line. Again, with heart sounds, we can use this mnemonic to remember where each of our heart sounds are. All people enjoy Time magazine. So A will be aortic, P will be pulmonic, A will be Ebbs point, T will be tricuspid, and M will be mitral. So the aortic heart sound is heard on the second intercostal space to the right of the sternum, while the P, pulmonic, would also be heard at the second intercostal space to the left of the sternum. E for enjoy will be our Ebbs point, where we hear our S1, S2 heart sound. It's usually heard at the left intercostal space on the third intercostal space to the left. So that's where we can hear our Ebbs point, at the third intercostal space to the left of the sternum. And T for Time magazine will be our tricuspid, which is usually heard at the fourth intercostal space on the left sternal border. So just right about the sternum area on the left intercostal space, on the fourth left intercostal space. And then we have our mitral heart sound, which is heard at the left fifth intercostal space, just medial to the mid-clavicular line. Again, we could also listen for murmurs when we assess the heart murmurs. There are three basic factors that can result in murmurs. Remember, murmurs are those abnormal sounds that are caused by turbulence within the heart valve. If you remember, turbulence within a blood vessel is called a bruit, while turbulence within the heart valve is called a murmur. So like we said, three basic factors can result in murmurs, which would be a high rate of blood flow through a normal or an abnormal valve. It could also be caused by blood flow through a sclerosed or abnormal valve or into a dilated heart chamber or vessel. Again, it could also be caused by blood flow regurgitated backwards through an incompetent valve or maybe a septal defect. So those are reasons why we might hear a heart murmur. Again, in assessments of the peripheral vascular system, we want to know where each of your, where you can assess for our pulses, especially like your dorsalis pedis or the apical pulse and all of that. Again, this would help you with the Nclex. Another important assessment with peripheral vascular system would be our Allen's test. Remember, the Allen's test is done before we draw up our arterial blood gas. So with the Allen's test, just a reminder, the ulnar nerve, the radial nerve are both occluded, and then the ulnar nerve is released to see what your collateral blood circulation looks like. So it normally should return to pink, but if it doesn't, it tells us there's a problem with circulation and we won't be using that artery. Again, you want to know where your pulses are located. So that's a carotid pulse, the superficial temporal pulse, external maxillary pulse. Those are our brachial pulses. These are our femoral pulses of femoral artery. We can feel or assess or palpate for popliteal pulses just behind, and then the posterior tibia and dorsalis pedis. And again, when you assess for this pulse, you want to assess the pulse force, and it's recorded using a 4-point scale. So if the pulse is absent or non-palpable, it's a 0. A +1 tells us it's weak or diminished or steady. A +2 tells us it's normal or strong. A +3 tells us the pulse is full and bounding. So a +1 pulse, tells us maybe there's a decreased stroke volume, and it's usually associated with conditions such as heart failure or hemorrhagic shock or even a heat exhaustion. Whereas a +3, which is full and bounding, may reflect an increased stroke volume and can be associated with exercise, even stress, as well as abnormal heart states like fluid overload or high blood pressure. Still on the peripheral vascular system, we want to assess for a pulse deficit. A pulse deficit is actually the difference between the apical and your peripheral pulse rate. Remember, every time the heart beats, there's a pulse rate. But there are times when the heart beats faster than the pulse rate. So when there are fewer pulses than heartbeats, a pulse deficit develops. This is sometimes referred to as an irregular heartbeat, and it can signal an arrhythmia. Again, we want to assess the jugular veins. It's normally distended when the client lies flat, but are not visible when the client's head is raised 30 to 40 degrees. Again, a distended jugular vein can signal the presence of serious underlying issues, usually involving the heart and the lung. It could actually be a sign that something is causing the pressure in your veins to rise. Again, let's look at neurovascular assessment. With neurovascular assessment, we are looking out for neurovascular compromise. We need to carry out early recognition of neurovascular compromise, especially for compartment syndrome. So we are looking out for impaired blood flow to the extremities, which could lead to loss of limb. We're also looking out for damage to the peripheral nerves, which could result to neurovascular deterioration, which can occur late, maybe after surgery or after trauma, or even after they've applied a cast. Neurovascular assessment evaluates the 5 P's, which include P for pain. So you want to assess if your patient can feel pain maybe on the toes. You want to assess for a pulse, especially in the limbs. You want to assess for pallor. Look at the color, assess for paresthesia. Can you feel this? Again, paralysis. With abdominal assessment, you want to know where each organ is located and relate it to the patient's complaint. for example, the right upper quadrant, I can see a major part of my liver. I can see some part of the stomach, the gallbladder, the duodenum, the right kidney, the pancreas, and even the right adrenal gland. And with the left upper quadrant, I can see a portion of the liver, the stomach, a major part of the stomach, the pancreas, the left kidneys. The spleen is also located in the left upper quadrant, and then the left adrenal gland. With the right lower quadrant, the appendage, reproductive organs, even our right ureter. And with the left lower quadrant, there's a left ureter and some reproductive organs. So you need to remember that all 4 quadrants contain portions of the small and large intestine. So if I see my patient with a right upper quadrant pain, I'm already thinking of maybe liver involvement. So when you want to assess the abdomen, you want to have your patients flex their knees, because this will help to relax the abdominal muscles and also provide for comfort. Again, inspect or auscultate before we percuss, and finally we palpate. That's the sequence for abdominal assessment. So you're looking at the symmetry, you're looking at the contour. Again, you can pause this video to get a quick view of how each of these quadrants and what they could be indicating. Again, with the abdomen, we're looking out for bowel sounds. There should be normal, high-pitched gurgles. You can hear that with the diaphragm of the stethoscope at 5 to 20 seconds interval, because if it's coming less than that, maybe less than 3 per minute, then you can say the bowel sounds are hyperactive. If it's more than that and loud, we can say they are hyperactive. Again, with abdominal assessment, you want to assess for peritoneal friction rub. So that would be peritoneal friction rub. So this happening here and this happening here. So peritoneal friction rub will be kind of a rough grating sound, like 2 pieces of leather rubbed together. And that can tell me there's peritoneal inflammation. Usually occurs over organs with a large surface area in contact with the peritoneum. So if we see a friction rub over the lower right rib cage, maybe from abscess or metastatic tumor, I'm already suspecting liver involvement. Or if I see a friction rub over the left lower rib cage in the left anterior axillary line, maybe from abscess or infection or tumor, I'm already suspecting a spleen involvement. Also, we want to assess for vascular sounds or bruits. And these are heard, or this indicates turbulent blood flow, especially when there's a constriction or there's abnormal dilatation or a tortuous vessel. So again, it could occur with aortic aneurysm. So this would be an aortic aneurysm. So we can hear the bruits there with our stethoscope if we listen with the bell. It could also be a renal artery stenosis. So usually you're going to hear this towards the flank. So that would be a renal artery stenosis. Or it could also be a partial occlusion of the femoral artery. So once there's an obstruction in the artery, we can hear an arterial vascular sound. Again, you also want to look out for lymph adenopathy. That refers to lymph nodes that are abnormal in size. It could be caused by bacterial infections or viral fungal infections. Ordinarily, lymph nodes are not palpable in adults, but a lymph node that is palpable and firm and non-tender could be a normal finding, especially if the client has had a trauma like a recent mastectomy, which can cause inflammation and lymph flow interference in that area. So in that kind of patients, you can see a lymph node that is palpable, it will be firm, or it would not be tender. But if the lymph node is tender and hard and fixed and enlarged, it's an abnormal finding and could indicate malignancy. Again, we also want to look out for rebound tenderness. That refers to pain or tenderness that occurs upon sudden release of pressure on the abdomen. Again, it could be as a result of inflammation of the peritoneum. And then we need to look at neurological system assessment, where we are assessing for deep tendon reflexes. So you want to assess sensory and motor pathways. You want to compare them bilaterally. And it's graded from 0, which is absent, to 4, which is hyperactive. So again, usually Absent reflexes are caused by an issue with the nerves and the tendon and the muscle. So again, in clients with absent tendon reflexes, or what we refer to as areflexia, you would also see weakness or twitching or atrophy in those patients. We also need to assess for cerebellar function. Remember, the cerebellum is responsible for equilibrium, is responsible for coordination and smoothness of movement. Some specific tests are used to evaluate cerebellar function, which would assess the gait and balance. One of that would be our pronator drift. So here the patient is asked to hold both arms at 90 degrees flexion and elbows fully extended at shoulder level in front of them with the palms upwards. And you want them to hold that position. If they're unable to maintain the position, or you notice one arm is drifting away, that could indicate a palsy with this patient. We can also carry out the finger to nose test. This measures smooth, coordinated upper extremity movement. So you want to have the patient touch the tip of their nose with their index finger. So you are looking out for evidence of intention, tremors, or dysmetria. Dysmetria is evidenced by difficulty in controlling their range of movement. We can also do the heel to shin test. So this test measures coordination and may be abnormal if there's loss of motor strength, proprioception, or a cerebellar lesion. And finally, we can do a gait test. So here the patient is instructed to walk, placing one foot directly in front of the other, heel to toe. Abnormalities in heel to toe walking may be due to maybe intoxication or weakness or poor position sense, or maybe vertigo or leg tremors. And finally, we want to carry out assessment of their levels of consciousness, and we can use our Glasgow Coma Scale. The GCS assesses a person based on their ability to perform eye movement, the ability to speak, and the ability to move their body. So again, no ability, we're going to give them for the eyes. If there's no ability, okay, so for the eyes, you want to remember, this person has 4 eyes, he's putting on glasses, so I know it has a score of 4 points. For the eyes, verbal V is like the Roman numeral for 5. So that reminds me that there are 5 points when I'm grading verbal response. And then motor, my car is a V6 engine, is a motor, is a V6 engine. That reminds me I have 6 points when I'm grading for motor responses. Again, you want to pause this video and come back to this slide. But remember that decreased LOCs could be an indication of something worse, maybe a new onset confusion and agitation. That should be worrisome to you. Maybe you're talking to the client and they are dozing off while you're talking to them. It could be, for example, if it's on a narcotic medication, it could cause sedation, and that sedation can also cause respiratory depression. So you want to carry out a quick assessment of your patient. So again, we're going to end with a quiz. The nurse is caring for a client with suspected Graves' disease, which assessment finding requires priority intervention. So again, I know that that new onset or agitation and confusion tells me there's a decrease in levels of consciousness, and number 4 would be my correct answer.